for a kind invitation and for opportunity to speak at such a wonderful Congress. I have no conflict of interest to declare. Severe aortic stenosis affects more than 1 million people aged over 75 years in Europe, and with an aging population, the number of cases of severe aortic stenosis will keep increasing. Moreover, it is believed that the number of diagnosed cases of aortic stenosis is twice as large as the diagnosis event. The incidence of aortic stenosis per 100,000 persons per year are 56 for male and 49 for female. This meta-analysis demonstrated that early surgery is associated with a significant reduction of all-cause and cardiovascular mortality in low-risk group. The introduction of TAVR created a clinical science revolution that increased the quality of AVR care. The population of TAVR have been continuously growing in recent years. For now, current American guidelines recommended TAVR for patients younger than 65 years, shared decision-making for patients aged 65 to 8 years, and TAVR for patients older than 80 years or who have a life expectancy less 10 years. European guidelines are more conservative, recommending TAVR for those aged to 75 years. So American guidelines suggest TAVR for patients older than 65 years. European guidelines recommending TAVR for those aged over 75 years old. Here's the algorithm of a heart team work on choosing the optimal treatment strategy for aortic stenosis, taking into account the main clinical parameters of the patient. Since some considered it possible to raise the issue even more radically and determine their strategy lifetime management according to patient's life expectancy. However, latest meta-analyses have been demonstrated TAVR associated with better long-term survival. Among low-risk TAVR was associated with high index morbidity and mortality, but better 3 years survival compared with TAVR. Moreover, in patients with severe aortic stenosis and coronary artery disease, TAVR plus PCI was associated with increased risk of all-cause mortality. Despite the obvious tendency to increase the implantation of biological valves, reoperation rate were consistently higher for biological valves. On the first time, the term of PPM firstly was introduced by Professor Himtullah in 1978. PPM occurs when the AOA of prosthesis is too small in relation to patient's body size cardiac output requirement. The normal valve structure, a small indexed AOA, and the high residual gradient following AVR is revealed. PPM was highly associated with long-term all-cause mortality. Among the predictors of PPM, the most important are small aortic annulus and small prosthetic valve size. It should be noted that we can overestimate of PPM by AOA measured by echo. One of the first large meta-analyses that revealed the direct effect of PPM on mortality. Results of partner 1A trial, TAVR is patients with small aortic annulus, have been associated with a higher rate of moderate to severe PPM. TAVR was associated with lower rate of moderate to severe PPM compared with SAVR. In patients undergoing TAVR, midterm mortality was low among those with smaller annulus. In vivo trial, there were no evidence of contemporary TAVR superiority versus SAVR in valve hemodynamic outcomes, with relatively low rates of severe PPM in both groups. Incidence of severe PPM is markedly lower, which predicted versus measured AOA. In SAVR, severe PPM by the predicted AOA methods are rare. Most of TAVR and SAVR trials are collected here. In general, we can talk about a great impact of PPM on SAVR. This meta-analysis found that moderate severe PPM is associated with a significant increase of perioperative, early, mid, and long-term mortality rates after SAVR. When we're choosing a prosthesis and other methods, we must understand that the course of PPM varies from patients to patients, and we should especially avoid severe in some specific group of patients. An important Fleming study in more than 600 patients demonstrated the effect of PPM on accelerating the degeneration of biological valves. The VIVID registry was confirmed the effect of predictive PPM in more than 1,000 patients in long-term survival. The results of this study suggest that PPM has a negative long-term impact on outcome after TAVR. These findings emphasize the importance of preventing of PPM. Here are the characteristics of modern valves. I want to draw attention to the good performance of mechanical valve. We conducted a retrospective non-randomized study to compare two groups of AVR. First, mechanical, 43 patients, and second, standard biological prosthesis, 40 patients. In hospital outcomes, as well, follow-up to 1, 6, 12 months, respectively, after the surgery were evaluated. We don't find statistical differences in baseline characteristics. In echo date was the same, and intraoperative parameters. We have better results in mechanical group in mortality and morbidity. We have better echo results in mechanical group also. Laser peak and mean gradient in mechanical group were revealed. No significant differences between two groups of AOA. In conclude, severe PPM is associated with increased risk of mortality after SAVR. PPM may accelerate the structural degeneration of bioprosthesis. Long-term AOA after SAVR with mechanical prosthesis is better than AOA in young patients with bioprosthesis. Pre-existing PPM may compromise the hemodynamic and clinical outcomes after valve-in-valve TAVR. PPM has minimal impact on short-term outcomes following TAVR. PPM may impact TAVR durability and thus negatively impact long-term outcomes. The impact of severe PPM outcomes is less important than that of moderate PPM. Options to prevent PPM use valve substitute with larger AOA, aortic enlargement, use TAVR and mechanical valve. Thank you for the attention.